Hi everybody, this is Dr. Peters and I'm going to be doing the upper GI wrap-up. I'll be talking about nausea, vomiting, GERD, meaning gastroesophageal reflux disease, GI bleeding, gastritis, and peptic ulcer disease. We're going to first start with nausea and vomiting, and if you take a look here, actually GERD, GI bleeding, gastritis, and peptic ulcer disease can lead to nausea and vomiting. On this next page, I drew a picture, which please don't mind my terrible art, but know this is a face here, and this is the mouth, the throat, and the esophagus right here. Now below here's the esophageal sphincter. You go right into the stomach, which is the antrum. The pyloric sphincter is here, and then the duodenum going down here. As you can see here, when you swallow food, it goes down to the esophageal sphincter, and then it empties into the stomach, and then it empties into the duodenum. The actual definition of nausea and vomiting is the expelling of gastric contents for some reason or another, and sometimes it can be for unknown etiology or we don't know the cause. Other reasons would be the topics that we're going to talk about, but also if you have an infection, sometimes gallbladder issues, pancreatitis, if you're undergoing chemotherapy, medication, side effects. When somebody has nausea and vomiting, the goal is to find the underlying cause. And while nausea and vomiting is usually self-limited and you can treat that at home, there are many cases where they can have complications. So if you are losing gastric contents, just think about you're losing electrolytes, and so you can become dehydrated. So it's really important to monitor somebody that comes in through the emergency room or is post-op or just in the inpatient as in general for any other comorbidity or nausea and vomiting. So usually with these type of people is you want to give the bowel a rest or the stomach a rest, so they would be made NPO most likely, and then once they start feeling better, you'll be giving them antiemetics such as Zofran, and then when they're feeling better, you can start them on, usually you start with clear liquids and move up from there. You want to be very careful not to give the patient any acidic drinks such as coffee or orange juice. You want to give them bland food, so think clear liquids. Also, to prevent dehydration, most patients will most likely get IV fluids. And if they are sick enough to go to the hospital, one of the primary things that you really need to do is give IV fluids. Number one, to rehydrate them and to prevent further electrolyte loss. If it becomes really bad, and let's say they have a GI bleed for some reason, due to an ulcer, gastritis, among other things, sometimes you need to put in an NG tube. You should have watched the NG tube video that Dr. Woda put up. Now let's talk about GERD, which stands for gastroesophageal reflux disease. If you look here on the picture, you can see the esophageal sphincter, and sometimes that does not work as well, or it can be from other things, such as pregnancy. If you're pregnant, then the baby is pushing up on the diaphragm, therefore pushing food contents back up. Symptoms of GERD are dyspepsia, burping up food, burping up water, burping up acid, and just feeling an overall burning sensation in the esophageal area. So it's usually mid-chest. Some people can have referral to their back, but mainly you have issues with the throat and the esophageal area. So one of the main treatments for this is prevention. Although we will be treating with medications including H2 blockers such as Pepcid, ranitidine, which is Zantac, as well as proton pump inhibitors. Proton pump inhibitors include your Prevacid, Prilosec, Zegerid, Acifex. There's a whole slew of them. So make sure you understand the difference between the two, which is the H2 blockers decreases the acid production. So that's your H2 blockers. And then the proton pump inhibitors, think about the proton pumps that you have in your stomach, and those are shutting down the proton pumps that produce the acid. So understand the difference between the two. So if someone has GERD, most likely the first recommendation is to recommend an H2 blocker. See if that will help decrease the acid in the stomach, therefore decrease the acid that's in the esophageal area. If that doesn't work, then you can go on proton pump inhibitor to actually shut down the proton pumps to help that. Now, guidelines are if you continue to have acid or acid reflux, then you really should go see a GI doctor for an endoscopy after 3 to 4 weeks if there's no relief in symptoms. Because just a side note, what happens is the stomach is acidic and the esophagus is more alkaline, and it's meant to be that way. So if there's something wrong with too much, say you eat too much at a meal and it's pushing up in the sphincter, the acid gets into your esophagus and can change the makeup of the cells. That's when you can have something called Barrett's esophagitis or eosinophilia, and that can cause cancer. Other treatment and prevention methods are to take Tums. That is safe. Just make sure patients don't take Alka-Seltzer or Pepto-Bismol, as that has salicylates in it and can cause a GI bleed. So you can take antacids, recommended between the meals and before bed. Also, make sure you tell them if they're laying down, keep the head of the bed up, or they can put something underneath the mattress to help prop the mattress up, which will help, because think about, again, going back to this slide, it's gravity. Food's pushing up. So if you're laying down, the food is going to tend to come up more into the throat and the mouth. So gravity is what helps. Also, smoking is a big trigger for that. It increases acid. So no smoking. Also, decrease food intake at meals, meaning smaller portions are always better. Stay away from food triggers such as peppermint, spearmint, tea, coffee, eating large meals, and like I said, smoking, and keeping the head elevated. To break this down even more, let's put GERD here. So remember, GERD is dealing with the esophagus. When you're thinking down in this area, that's the stomach, so you can have gastritis. So gastritis, remember to break down, itis is inflammation of, and gastro is the stomach. So inflammation of the stomach, which can be from a variety of things, including infection to an ulcer causing that, as well as many other reasons from medications, or even people that drink energy drinks can cause that. Then we have ulcers. So we have a gastric ulcer, and then we have duodenal ulcer. So when you think about, remember the duodenum is over here, so we have a duodenal ulcer. What symptoms are they going to have? Well, it's depending on what is going on. So when you ask patients and do a really good history, you can get an idea of what you think is going on, such as having esophageal issues and dyspepsia. Remember that burping, you would suspect more GERD. What if they're having pain up in this area? Then you would think, okay, do they have gastritis, or do they have a gastric ulcer? And also you have to keep in mind when they're eating. So if they ate a meal and if it's within about 2 hours, you would suspect if they have pain within 2 hours, it could most likely be a gastric ulcer, because stomach is most likely still in the stomach. But if after a couple of hours you have pain after eating, and pain after eating is more mid-epigastric, so it's down lower, then you most likely have more of duodenal issues, because remember, the food content's now going down into the duodenal area. Any of these things can cause a GI bleed. So if you have an upper GI bleed, you're usually going to vomit bright red blood, because remember, it's still fresh and it's close to this gastric area. Now, if you have a bowel movement if you have an upper GI bleed, a bowel movement's going to be dark, because it's gone through the GI tract, the lower GI tract, and it has since broken down, and so it's coming out as dark blood. It's digested. I have seen GI bleeds time and time again, mostly in older people, for taking too many NSAIDs. This can happen in anybody, though, and doesn't necessarily age discriminate. But patients with arthritis tend to take more ibuprofen and Aleve because they say Tylenol does not help, and they think it's over the counter, so it's safe. And even younger people that just have chronic pain, they think that they can take it every day. Well, it erodes away at the stomach lining and therefore can cause a bleeding ulcer in one spot or another. So if you end up having a GI bleed, think about if they present to the emergency room, they're losing blood, they're going to be anemic, they have a risk of hypovolemic shock. So remember, you want to make sure that you're doing your ABCs and most likely giving them IV fluids or fluid bolus, but you want to make sure you do an assessment before you do that. If you have an elderly patient that comes in that has heart failure, you want to be careful about giving the fluid boluses. And you're preparing these people to go for an upper endoscopy, and I'm just talking upper GI. If you suspect lower, many times they'll do an upper endoscopy and a lower endoscopy, meaning colonoscopy, and taking the tube and going down the throat and taking a look to see where the bleed is and take care of it. They can cauterize it. There are some times where they go in and they really can't find the bleed, or the bleed has resolved itself, which that can happen. So in summary, nausea and vomiting, that can be caused from all of these listed below, as well as other reasons that we talked about before. But remember, nausea and vomiting can cause dehydration, electrolyte imbalance. Make sure you know your signs and symptoms of dehydration. For example, if they have very concentrated urine, are they dry? Are they not feeling well, feeling dizzy? Check their skin turgor, and maybe they're thirsty. So make sure you understand the signs and symptoms of dehydration, as well as complications of nausea and vomiting. Then we go to GERD, know your symptoms, treatments, and prevention that we talked about, gastric and duodenal ulcers and complications. Also, remember your gastric ulcer, duodenal ulcer, and the difference. So what kind of symptoms are the patient going to present with? Eating 2 hours after eating or less, or is it going to be more? And is it going to be suspected as gastric ulcer or duodenal ulcer? And then GI bleed. GI bleed is complication from ulcers, as we talked about, having too many NSAIDs, which is one of the most common reasons for a GI bleed, and understand the treatment. Also make sure you review NG tube, how to insert, how to remove, why is that used, and complications. So what do you have to watch for when you have an NG tube, especially on suction? What are the complications?